Hello and welcome to our webinar today, Tips for Treating Insomnia in the Elderly. This project was facilitated by the California Culture Change Coalition under contract number 13-20-555 with the California Department of Public Health and funded by the Centers for Medicare and Medicaid Services for the California Partnership to Improve Dementia Care. My name is Martha Pauley. I'm a faculty member at California North State University College of Pharmacy, a board-certified psychiatric pharmacist and certified geriatric pharmacist. I've been a long-term care consultant for many years. I have no relevant financial relationships to disclose. What are our goals for today? As a pharmacist, we are an advocate for delivery of healthcare that is person-centered and goal-directed. And we can also advocate for appropriate use of drugs for insomnia in the elderly. This would be using them after non-drug treatment and sleep hygiene has been maximized. And we've provided patient and caregiver education. We need to pay attention to the benefits and risks of the drugs when we begin to use them. We need to consider short-term use and individualized choice. What is insomnia? Just very simply, it's a subjective report of insufficient or non-restorative sleep. That might mean difficulty falling asleep, maintaining sleep, waking too early, or feeling unrested, and it occurs despite adequate opportunity to sleep. Difficulty falling asleep is usually called sleep latency. Maintaining sleep or staying asleep is usually the most significant issue that faces elderly people, but it can be any of the categories listed. Feeling unrested speaks to the quality of sleep. It may not be good as far as resident feedback. Insomnia can take different forms. There can be a transient form, which lasts only days to weeks, or a chronic form, which lasts greater than 6 months. Risk factors for insomnia are listed there. Depression and female sex and older age are common risk factors. Also, lower socioeconomic status, comorbid medical and psychiatric conditions, and social issues such as divorce or separation, and African Americans seem to be more at risk for insomnia. Insomnia is common in elderly patients. In patients aged 65 and older, at least 50% report a sleep disturbance, so it disproportionately affects the elderly. It is not considered a normal part of aging. And in some institutions, it may be up to 2/3 rather than the 50% that report a sleep problem. There are age-related changes in sleep patterns. Less sleep is needed sometimes in the elderly, although this may be controversial. And generally, the elderly do have more trouble falling and staying asleep. Underlying illness plays a big role. Medication side effects or adverse events also contribute. There are risks associated with untreated insomnia as well. So people that suffer long-term insomnia have impaired cognition, memory, and daytime performance. They do report fatigue and irritability. They have greater risk of trauma and falls, and in general, increased healthcare costs. These can be related to headaches, GI concerns, anxiety, congestive or chronic heart disease, and depression. Insomnia does carry personal, caregiver, and societal burden. When we encounter a resident with insomnia, we need to think of a couple things. Medical and psychiatric causes, psychosocial issues, environmental, and drug-induced causes all play a role. We can resolve these contributing elements in many cases. And then today we're also going to review treatments, either pharmacologic or non-pharmacologic. What conditions contribute to insomnia? It's very important to have a medical and psychiatric history. Medical causes are many. These can range from neurologic, stroke, migraine, Parkinson's disease, Alzheimer's disease, sleep apnea, restless leg syndrome specifically. It can also occur from other causes, COPD, asthma, or other troubles with breathing, chronic pain, hypo or hyperthyroidism, GI conditions such as reflux or GERD, cardiovascular conditions, and general disability and pain. all are contributors and causes to insomnia. Looking at psychiatric causes specifically, there are also many: depression, anxiety, bipolar disorder, substance abuse, drug or alcohol intoxication or withdrawal. And then looking psychosocially, jet lag, daytime napping, lots of noise, different or poor conditioning, and poor sleep hygiene. We have treatments that are non-prescription and prescription when we look at drugs, but these also can be contributors to insomnia. Medications that can cause insomnia. These can, as you see, we can name some things that are over the counter, and we can name some meds that are prescriptions. Antidepressants, for example, commonly SSRIs, may contribute to insomnia. Any class of antihypertensives may do so. Steroids, decongestants, we know Sudafed, for example, can cause insomnia. As far as antihistamines go, the second generation agents may cause insomnia. We're used to thinking of first generation antihistamines as causing sedation, but here the second generation drugs may do the opposite. And then the list goes on, as you can see. Statins, adrenergic agents, glucosamine, cholinesterase inhibitors, stimulants, and then caffeine, alcohol, and tobacco. Donepezil, for example, can cause insomnia in up to 14% of cases. Let's review the sleep cycle. As you can see, there are 3 stages: light, deep, and REM. Light is composed of 2 stages, 1 and 2, deep, 3 and 4. This is the delta wave sleep or slow wave sleep. And then REM is the rapid eye movement sleep. So the deep sleep is the first half of the sleep period. It's a restorative phase. And then the REM sleep is the second half of the sleep period. It's a dreaming phase and also a restorative phase. Disruptions here lead to daytime sleepiness, poor concentration, and fatigue. Stages 1 through 4 are non-REM. So with the elderly, we are looking at some changes. Sleep initiation is more difficult. The total sleep time decreases. Elderly stay longer in light sleep, and the delta and REM sleep decreases. So they have more sleep fragmentation. Daytime napping increases, and time in bed not asleep also increases. So normally people cycle through this non-REM and REM sleep stages every 90 to 120 minutes. We know that natural physiological changes in circadian rhythm influence the fact that elders go to bed earlier and earlier and wake up earlier. Sometimes this can even begin to reverse the sleep-wake cycle. Much of the elderly disturbance in sleep is from physical, psychiatric, and medical causes. You hear the term sleep hygiene. So what is good sleep hygiene? Before we consider what the elements are, we need to obtain a detailed sleep history. That's important. And family can help identify what are poor sleep habits that maybe the individual has, and this might help us find a way to help them. So some elements of good sleep hygiene: keeping the patient's room dark and comfortable and quiet in the evening, and that means no TV or bright lights in the bedroom. Something as simple as not watching TV in bed can have a profound effect. Also decreasing noise. Establishing a regular sleep cycle 7 days a week is important, not just during the day, during the week, days, and not the weekend. No heavy meals and limiting liquids before bedtime might be a good suggestion. Avoiding daytime naps, even after a poor night of sleep, or limiting naps to 30 minutes a day, and using the sleep diary. So the sleep diary, writing down when a good night's sleep occurs and when a poor night's sleep occurs, might help identify problems or issues. Here are some other suggestions. Relaxing before bedtime, that might mean having a warm bath or bathing prior to bed. And then also thinking about caffeinated or stimulant drinks in the afternoon and limiting those. Avoiding alcohol, nicotine, and caffeine. Some exercise is suggested, but it needs to occur 6 hours prior to sleep. So light exercise. And then occasionally removing a clock from view is helpful so that people don't wake up and look at the clock as it advances forward through the night. Recently, there have been some suggestions that the use of quetiapine for sleep might be a proper indication, especially in those with dementia. We're talking generally low doses here. It's a new trend. The doses are usually under 100 milligrams, but this trend is not supported by evidence. Most of the studies that look at quetiapine for sleep are done in young and middle-aged adults. There's a lot of diagnostic variability, small samples, and even those studies suggest that the use should be limited to those with comorbid psychiatric disorders. One of the reasons quetiapine has been looked at is because it has a variety of mechanisms of action. It has receptor actions at a variety of sites besides dopamine. But if we're suggesting that the sleep benefit mechanism is maybe histamine or serotonin receptors, then we definitely can make a less toxic choice, such as trazodone or mirtazapine. And we're going to talk about individual agents as we go through today. Choosing Wisely is a program promoted by the American Geriatric Society. We talked about these in our first seminar, and I bring to your attention this Choosing Wisely suggestion from the American Psychiatric Association. Don't routinely prescribe antipsychotic medications as first-line intervention for insomnia in adults. And they cite inadequate evidence. So just what we've been talking about. The studies that are there are open label and case reports, and just very small in number, not really considering elderly or those with dementia. So let's look at some of the agents that we might have occasion to use. What about melatonin? This is a neurohormone. It's produced by the brain during the dark hours of the sleep cycle. It's an antioxidant and sleep inducer. Doses have been promoted from anywhere from 1 to 10 milligrams, taken several hours before the desired sleep onset. The problem, or a problem with melatonin, is that dose and purity is not established since this is a dietary supplement with no FDA oversight. But side effects are minor. Some sedation, some fatigue, possibly hypothermia. And there is evidence of help in dementia. There's evidence cited is that melatonin levels may be decreased in those with dementia. And this is an interesting area of research. Continuing on, what about other OTC agents? And here we're talking about the old antihistamines, things like Benadryl or Atarax or Unisom. And then these agents combined with Tylenol or acetaminophen or NSAIDs in things like Tylenol PM or Motrin PM. So as you probably know, the efficacy past a few days of sedation is not proven. They're definitely on the AGS Beers list with a strong recommendation to avoid. The main reason is that they have strong anticholinergic effects, and to review those quickly: dry mouth, blurry vision, dry eyes, constipation, urinary hesitancy or retention, and then those are all below the neck, right? And confusion and delirium can also occur, especially with other CNS depressants. Looking on now to prescription agents. The first group of drugs that we're going to talk about are the Z drugs. They're thought to be safer than benzodiazepines because they were developed after the group of benzodiazepines. But I bring to your attention a report about doubling in the emergency room visits related to Ambien use during the period of 2006 to 2010. This is the Dawn report, and it's put out by the Substance Abuse and Mental Health Services Administration. In this report, they cite that the increase in ER visits occurs in both men and women, more so in women, and half of these emergency room visits were zolpidem with other meds. The greatest majority of these emergency room visits were in adults 45 to 54 years of age, but there was also a significant increase in older people as well. So this report is from August 2004. There was also a recent study by Berry et al. In JAMA in 2013 that found that the risk of hip fracture increased in skilled nursing facility patients who were prescribed a non-benzodiazepine hypnotic. So we'll talk about the specific agents in a minute, but now considering benzodiazepines, we do have a love-hate relationship with this group of drugs, and they do have multiple uses, including alcohol withdrawal, insomnia, anxiety, agitation, occasionally anticonvulsant, and muscle relaxant properties. So what are the shared things to think about when we look at Z drugs and benzodiazepines? They're both GABA-acting hypnotics. They have broad effects, including amnesia, next-day sedation, and rebound insomnia, and they're all habit-forming and may cause dependence to varying degrees. Let's look at the Z drugs. Of course, zolpidem is the most commonly prescribed, and because this has a duration of action about 8 hours or less, it is best for sleep onset mainly. The dose used to be from 5 to 10 milligrams, but we realize now that the 10 milligram dose is associated with a hangover next day effect. This has been a recent FDA warning about psychomotor impairment. Women are most susceptible to this, and so the dose really should be 5 milligrams, not 10 milligrams. It is helpful for sleep onset, as we said, and it's one of the most commonly prescribed sleep drugs in the United States. There are a couple of other forms, intermezzo and zolpidem, that are sublingual and oral spray forms that are occasionally used that have may have slightly different milligrams. The next agent is Sonata. It's really the shortest duration drug of the Z drug group with a duration of about 4 hours. The dose is 5 to 10 milligrams, so it's most helpful for sleep onset with that short duration, and it probably has the lowest risk of dependence and withdrawal. Lunesta is the third drug. It can be for sleep onset or maintenance. The dose is generally 1 milligram. The higher doses, 2 to 3 milligrams, are associated with the same hangover issue and FDA warning about psychomotor impairment. And it's been cited that the psychomotor impairment occurs even though individuals may not in fact feel it. It still may impair their driving ability, for example. The Z drugs are known for a group of behaviors called complex sleep-related behaviors, which might include sleepwalking, sleep eating, sleep driving. The new 2015 Beers list recommends avoid without a duration, whereas previously it was acceptable to use them up to a period of 90 days. We do generally accept that they have a lower risk of dependence than benzodiazepines. But the Beers list does cite delirium, falls, and fractures, and similar adverse drug events to benzos in the elderly. They even go on to cite increased emergency room visits and hospitalizations, motor vehicle accidents, and minimal improvement in sleep latency and duration. Benzodiazepines are our next group. So we know these drugs do decrease time to fall asleep. They decrease nocturnal awakenings, but they also might have an effect on REM sleep. And remember, this is a restorative phase, so disruptions here might lead to fatigue and poor concentrations. Rebound insomnia can occur from using benzodiazepines within 1 to 2 weeks of use. They may have a hangover. This is especially important in drugs with the longer half-life or active metabolites, where impaired psychomotor performance and memory next day does occur. One can develop tolerance to benzodiazepines, so initially they're very effective, but then this wears off over time. And there is a component of addiction. We're not just speaking about physiological dependence, we're talking also about addiction with long-term use, and the withdrawal can be very problematic. So what are the common benzodiazepines? Let's look at them in 3 groups here. Short-acting agents such as alprazolam or triazolam are listed with recommended doses, and of course use in the elderly is at the lower end of the scale here. Then there are intermediate acting drugs that are better for sleep maintenance, and the 2 most commonly used here are Ativan and Restoril. And then highlighted in the 3rd column are the long-acting agents, which are really best avoided in the elderly, such as diazepam or chlordiazepoxide or flurazepam. These drugs have long action and they have active metabolites which can build up over time, causing potential obtundation or excessive sedation and fall risks. So benzodiazepines are all Schedule IV drugs, and they have four main properties. They're a sedative, they're anti-anxiety, they have muscle relaxant and anticonvulsant properties, varying by degree as far as the different structures of the benzodiazepines and how they fit onto the various receptors. And of course, they are Beers list drugs. I might point out that the duration of action for triazolam is about 2 to 5 hours. It does have some drug-drug interactions, especially with cytochrome P450, 3A4 inhibitors. And then when we look at Ativan, it's best for sleep maintenance, as we said, because it has a slower onset of action. Looking at the longer acting agents, just as a comparison, flurazepam, for example, has a duration of 10 to 20 hours. So you could easily see how that could carry on to the next day. Temazepam is a commonly used agent. It improves sleep onset and sleep maintenance, and it has a duration of about 6 to 10 hours. So the reported increase in sleep time with benzodiazepines is about 40 minutes in normal adults, but the benefits to older people is less. I bring to your attention the Choosing Wisely program promoted by the American Geriatric Society that we talked about initially in the first webinar. The statement from the American Geriatric Society in regards to benzodiazepines is this one: don't use benzodiazepines or other sedative hypnotics in older adults as first choice for insomnia, agitation, or delirium. And they go on to cite the reasons that we've really discussed: risk of motor vehicle accident, falls and hip fractures leading to hospitalization and death can more than double in older adults. So that these are potential harms. We need to take care and consider these when we're developing our treatment strategies for insomnia, agitation, or delirium. Let's look at the prescription group of antidepressant agents as potential sleep helpers. So we do have trazodone or Desaril. Doses are usually low, such as 25 to 100 milligrams. We have an option with mirtazapine or Remeron, Ramelteon or Rosarum at 8 milligrams, and other sedating antidepressants, which are tricyclic antidepressants or with anticholinergic properties. Doxepin is kind of interesting because the new form of doxepin is Silanor, and the doses are 3 to 6 milligrams. It's the only antidepressant that does have the FDA approval for insomnia, but it is a TCA, so people are hesitant to use it. It's controversial if low-dose doxepin has strong anticholinergic side effects, but both doxepin and amitriptyline probably do. However, I want to point out to you that the Beers 2015 list does say that doxepin may be an alternative for against high-risk drugs at this new low dose. And the safety profile of this 3 to 6 milligram dose might be better, or in some ways similar to placebo, even though the package insert does warn against urinary retention and glaucoma. Amitriptyline is also an old tricyclic. Low doses, such as 10 to 25 milligrams, have been commonly used as a neuropathic pain adjunct and sometimes for sleep, but generally not recommended for the sleep indication. Let's look a little bit more specifically at trazodone. It is prescribed off-label, and the doses that we use as a sedative are subtherapeutic antidepressant doses. When we talk about antidepressant use, which is rare these days, we're talking about hundreds of milligrams, and here for this sedative use, we're talking 25 to 100 milligrams. We know that the effects may not last beyond a few weeks, and that this drug is generally not included in guidelines. There is a paucity of clinical trials assessing the efficacy as a sleeper in the geriatric population, especially long term. Rebound insomnia is something to think about. It might be significant after stopping use of the drug. Some side effects to monitor for include the following: nausea, constipation, headache, dizziness, and sedation. Orthostatic changes may be prominent, and anxiety and fatigue. And a problematic side effect of priapism can occur at doses that are this low, 50 to 100 milligrams. It's not a controlled substance. Next, let's look at mirtazapine. It is one of the most sedating antidepressants, and when we use it, we're hoping for a primary side effect of sedation when it's used. It can also promote weight gain in the elderly, but it might be a reasonable choice if depression or anxiety is a component of insomnia. Gait disturbances have been reported, and increased risk of restless leg syndrome or periodic limb movements in sleep. Lower doses are more sedating than higher doses. So the insomnia doses are relatively the same as the antidepressant doses, but may be on the lower end because of this phenomenon of the lower doses being more sedating. It's not a controlled substance. Ramelteon is a newer agent. It, like melatonin, is a melatonin receptor agonist, so they're related drugs. It's best for sleep onset insomnia and really not as helpful for sleep maintenance. We do have no comparisons with other sleep meds and similar side effects to other drugs: dizziness, nausea, fatigue, or headache. It does have some drug interactions. One that might be important is with especially donepezil. Donepezil can increase the levels of ramelteon to almost double, which may cause more side effects. But this drug has no potential for abuse and is not a controlled substance. It has about an 8-hour duration. Belsomra is our newest agent. It's an orexin receptor antagonist. This is a new mechanism. Orexin is also called hypocretin. It's a neuropeptide that regulates arousal, wakefulness, and appetite. So the way this works is that the drug promotes sleep by blocking orexin neuropeptides from binding to the receptor sites and sending the signals. So in other words, it suppresses the wake drive or inactivates wakefulness. It's indicated for sleep onset and sleep maintenance. Side effects are what you might expect from a sedative or a sleeping agent: next day sedation, headache, or cough. It does have some drug interactions to be mindful about. We don't have comparison studies with it versus other agents. It's very expensive. It's Schedule 4. What about herbal or alternative remedies? Lots of things have been promoted, and I list several of them here on the left. Chamomile tea, for example, kava kava, valerian, passion flower, coenzyme Q10, lemon balm, lavender, or skullcap are just some of the main ones that are considered in this category. They do have mild sedative effects, and there are different types of dosage forms, such as a tea or an oral pill or capsule, but we don't have a clear handle on optimum dose. We don't have a clear handle on purity of the product because these are supplements not controlled by the FDA, and we have really no convincing evidence of effectiveness. I highlighted kava kava and valerian because there have been reports with liver issues or toxicity reported. A good reference for these agents can be found in the Pharmacist Letter Natural Database. So what are the challenges of treating insomnia? Insomnia may be a symptom of many things, such as chronic pain, depression, anxiety. It can be a symptom of medical or psychiatric conditions, or a side effect of drugs, or a primary problem. But we do know that elderly have a lessened therapeutic response and heightened sensitivity to sedative hypnotics. So what does that mean? Well, the list of problems is lengthy: falls and fractures, confusion, excess sedation, hangover or daytime fatigue, dizziness, memory impairment, rebound anxiety or paradoxical reactions, and withdrawal issues. There may be a statistically significant improvement noted in sleep, but the magnitude of this effect is small. I point out to you one pooled analysis, that a meta-analysis that looked at 24 randomized controlled trials in people over 60. And these were people with insomnia, but otherwise free of psychiatric disorders or acute physical illness and not cognitively impaired. And what they found in this pooled analysis was that the number needed to treat is 13 and the number needed to harm is 6. So what that means is that adverse events were more than twice as likely as improved sleep when sedative hypnotics are used. I wanted to bring to your attention this hazard report. Benzodiazepine use is associated with an increased risk of Alzheimer's disease, per this report. An association was found even after adjustment of depression, anxiety, and insomnia. The risk begins after 91 days or more of therapy and increases for 180 plus days. Longer half-life drugs pose the greatest risk. There was no association with cumulative doses under 91 daily doses. This is a Canadian study that looked at almost 2,000 people and 7,000 controls. They found the association between Alzheimer's disease and benzo use started at least 5 years before the diagnosis. The effects that benzos have on memory and cognition are known, but this increased risk of dementia is newer, and the nature of this link is not fully defined. Benzo use might also be an early marker of a condition associated with an increased risk of dementia. As far as the mechanism, benzos may limit cognitive reserve capacity, reducing the ability to cope with brain changes. So let's review the goals of treating insomnia in the elderly. Our main goal is to improve sleep, and that's with next day benefits, not residual effects. We want to reduce distress and anxiety about sleep, and we want to minimize negative impact of insomnia on quality of life. So one of our first considerations is to use behavioral measures. We need to plan activities and keep an individual engaged during wakefulness, reduce time in bed, consider the good sleep hygiene suggestions, and provide education about sleep. Cognitive behavioral therapy is also widely studied, and it does have efficacy that is demonstrated. When we think about using meds, we need to assess carefully, ruling out the correctable causes first. Choosing the best individualized drug is important. Medication doses should be low and short-term, and we need to consider short half-life drugs primarily. So educating the patient about risks and benefits is important. And when we talk about short-term, we're talking 3 to 4 weeks if possible. When we talk about the best individualized drug, we're talking about paying attention to the drug-drug interactions, the safety profile, the side effects, and the type of sleep problems. When we consider discontinuation, it needs to be gradual. We need to monitor for rebound insomnia. Providing careful and ongoing monitoring of the resident is important, and this leads toward the goal of providing patient-centered care. Here are some resources that might be helpful to you. Thank you very much. This concludes our talk today. Thank you for listening.